on to types of cancerous tumors, and talking about how the germ levels, germ layers of the cell are going to determine how we name them. All right, so what you will see is the different kinds of cancers have a variety of names. So we have carcinomas, and carcinomas are things that are going to affect mainly organs. So we've got lung, which we said is the second most common type of cancer. Again, number one for men is prostate, number one for women is breast, and then for everybody, lung is 2 and colon is 3. So these are carcinomas. So typically we call these the hollow organs of the body because they are, even though they have stuff in them, they are still technically hollow. There are sarcomas, which are connective tissue related. So fat, bone, muscle would fall into sarcoma groups. Leukemias is referring to cancers of the bloodstream. Leukemias are interesting because they don't have a specific tumor. Instead, it's an abnormality with the amount of white blood cells, which is similar to lymphomas. Again, not a specific tumor, but an overproduction of certain types of immune cells like B cells. All right, so here is every prefix that you've ever wanted to know and what it means. So take a look at that. And again, if you just see a prefix plus an oma, that is generally going to refer to something benign. And you can read through these. I believe in you. All right, so let's just start with carcinomas. So carcinomas are generally going to be cancers of epithelial tissue. So these are going to affect the hollow organs of the body, and you'll see that carcinomas are about 85% of all tumors in the skin, large intestine, glands, stomach, lungs, prostate. Again, the hollow organs of the body. And there's also epithelial tissue on the skin, obviously, because that's what covers our body. The metastatic pathway of carcinomas, because they are hollow organs, they have a vascular supply. So typically you're going to see the vascular nature at the very top of the epithelial surface is not technically avascular, but it does derive the main amount of its nutrients via diffusion. So you'll see a lot of lymphatic metastasis. And now we're going to start putting some stems together with some prefixes. And we're starting with adenocarcinoma, or you can say adenocarcinoma. As long as you say it with confidence, you cannot go wrong. This is an adenocarcinoma of the colon. And I mentioned that when you look at a malignant growth, they're red, they are bloody, and they do not resemble the tissue of origin. So you would expect a colon to look like, this, but you would not expect it to look like this. This is your mass. So adenocarcinoma, adeno is a gland or an organ. Carcinoma is referring to the fact that it is epithelial tissue. We also said that linings of organs, including your skin, are covered with squamous cells. So here's a squamous cell carcinoma, which is a type of skin cancer. And one thing I want you to know about squamous cell carcinomas is that they are penetrating. So there's a sign in cancer that something is wrong when you have a sore that doesn't heal. That can refer to an early warning sign of a squamous cell carcinoma, because as you can see, this is quite a penetrating lesion. That's different than other types of lesions like a basal cell carcinoma, melanoma. Squamous cell carcinomas are penetrating lesions, especially on epithelial surfaces like the skin. Again, sarcomas, those are derived from connective tissue. So fat, bone, cartilage, and muscle would all be referred to as sarcomas. They are less common, but when they do occur, they spread very rapidly and they're quite aggressive types of cancers. This is a new term, anaplastic. So an we know is without, so plasia and plastic means substance. So anaplastic cells, they don't really have a form associated with them. They just look weird, which you can see even if we start with osteosarcoma, which means bone sarcoma. This abnormal bone, it doesn't look normal in any way. You have this nice cortical bone that you can see very clearly with the tibia and fibia, and then this is completely disorganized anaplastic cell matrix here. In this case, because these are so aggressive, if a patient has an osteosarcoma, it wouldn't be unusual for the leg at least above the knee to be amputated. They're very, very aggressive, so that's the way those are treated. Metastasis, because these are connective tissue related, there is a lot of vascularization in that area, so you'll see quite a bit of blood embolus metastasis. All right, so some other forms of sarcomas. Kaposi's sarcoma is a specific type of skin cancer that causes purple lesions. And you can see in this picture, the purple lesions have also extended to this patient's gingival surface, so their gum surface. You can also see this white flaky portion here. That is referred to as leukoplakia. Leuco meaning white, which is actually a precancerous sign. So when that would be the first thing that occurred. But Kaposi's very specifically is associated with purple lesioning of that area. So we're calling this intraoral, so inside the mouth, Kaposi's or purple lesioning sarcoma. Here's a liposarcoma, lipo meaning fat. And fat is a connective tissue, so that's why we have sarcoma. And this is kind of difficult to guess the organ unless you take the full picture into account, which is cut off a little bit. So there's a couple areas in the body that are almost all fatty tissue. In females, it's the breast, and in males, it's the testes. So this is actually testicular liposarcoma. And what they've done is bisected a healthy testis here, so you can actually see the spermatic cord that's been removed, and they've bisected it and squeezed it so that you can see the healthy fat inside of a healthy testis. Where here, when they've bisected this liposarcoma, this is an abnormal amount of fat, abnormal color. This is some caseating looking tissue. You'll also see it's red, it is bloody, and this is the shaft of the penis. And that is a very highly aggressive cancer and definitely bad news. So sarcomas are connective tissue type of lesions. Leukemias, as we mentioned, leuko is white, so it's a neoplasm of blood cells. There's no distinct solid tumor. Instead, what you see is all of the energy in the body essentially is being shifted to hematopoiesis, which is the formation of blood cells. But instead of seeing 95% of the circulating cells being red blood cells, in this case, they're abnormal white blood cells. So what this means is there's going to be symptoms of anemia. So if you look here on the smear, there are very non-prevalent red blood cells. And you know, when you don't have enough of them, you feel tired, lethargic, you don't have great color. And then we see this massive amount of white blood cells. So this is about 100-fold of what you would normally see in a blood smear. So this, in that case, is the tumor. It's that the marrow is now making too many white blood cells, which should be matured before they exit the bone marrow and enter the circulation. But another problem with leukemia is that the marrow can actually spill out immature cells, which can continue dividing in the bloodstream so that they are extremely prevalent. So leukemias are not associated with a typical tumor lesion, but instead an excessive amount of white blood cells being created by the marrow. In that case, you would want to suppress marrow activity. And that's done using chemotherapeutic or radiation agents to ablate or remove the existing bone marrow, to prevent so much activation of this pathway. In that case, if there is ablation of the bone marrow, a bone marrow transplant would be necessary. So you would have hopefully healthy marrow that's put in there. There's also drugs that can suppress marrow production of white blood cells that we'll talk about in the treatment portion. All right, and then similar to leukemias are lymphomas. So this is a neoplasm of lymphoid tissue. It's almost always malignant. The word lymphoma itself means malignant, and there are two different types that get their classification, which is a really terrible classification system. The individuals who discovered the cell that we'll talk about next, the Reed-Sternberg cell, love their names, and they love naming things after themselves. If you see this cell, the Reed-Sternberg cell, it's classified as Hodgkin's lymphoma. If that cell isn't present, it's referred to as non-Hodgkin's lymphoma, which I say is a bad characteristic or classification system because there are many, many types of non-Hodgkin's lymphoma. So essentially, you're either seeing a cell or you're not. The basis of classification has to do with how many lymph nodes are involved. So you will see swelling of lymph nodes in lymphoma because there is a huge amount of these immune cells becoming activated. And additionally, if it's a B cell tumor, so B cell lymphoma, which is a pretty common type, they're also secreting a liquid substance called antibody, which is going to further increase the amount of swelling that you'll see in the lymph node areas. Prognosis is a term for your overall outlook. So if it's a low grade, again, that's something that we'll go over in the grading and staging, but grading of a cancer is done by the pathologist, and it takes into account how quickly the cells are dividing and how similar or dissimilar they look to the parent tissue. So a high grade means it's growing really fast and the cells don't look great. If it's low grade, it's growing more slowly and the cells are more normal in their overall appearance. Excuse me. So there's pretty favorable prognosis for low-grade lymphoma. High grade or even intermediate grade lymphoma with really fast proliferation of cells has a generally poor overall prognosis. 75% of lymphomas arise from B cells, so the cells that help make antibody. And the cell of note, because it's going to drive Hodgkin's versus non-Hodgkin's here, is the Reed-Sternberg cell. And this is a cell that, when viewed, has nuclei that look as if they are viewing each other in a mirror image. There's a science word for that. We'll talk about it later. You don't need enough. You have enough to confuse you. So we have these mirror image nuclei and a surrounding halo. This is the characteristic Reed-Sternberg cell. And again, if this is viewed in a blood smear under fluorescence, then this patient would be classified with Hodgkin's lymphoma. If this wasn't present, it is non-Hodgkin's, and there are about 19 different types of non-Hodgkin's. So again, poor classification system, but definitely know the Reed-Sternberg cells. Okay, just going through some different skin tumors now. Skin cancer is a very common type of cancer, and just taking into account the anatomy, there are multiple cell types in the epidermis. There's cells that make keratin, there's cells that make melanin or pigment, there's basal cells that help provide the basis for cellular division and mitosis so that the new epidermal cells are filled in. And then there are squamous cells, which represent the upper or most outer layer of the cells that proliferate from the level of the basement membrane, or what we call the basal cells. So those cells, depending upon which one becomes damaged or overactive, are going to determine the lesion characteristics. So we'll start with a term that, again, when you see a stem and oma, you typically think benign. So the full name for melanoma is technically malignant melanoma, but many people drop the malignant and say melanoma. This is a cancer, and a pretty aggressive cancer, of the melanocytes, which are the pigment-forming cells in the skin. Just a little note, there are benign lesions of melanin-producing cells. These are sometimes referred to as birthmarks or stork bite or a nevus in Latin. And as long as it looks the same way and it's not changing shape over time, and it's not changing coloration, these are pretty much benign and they just need to be watched. Over time, especially if they're raised like this, they will go through the same sloughing procedure that happens with your healthy skin. So if there's any damage to this raised area, then that will have quite a strong reaction to that damage. So ideally, somebody with one of these, if you have a birthmark, you just kind of keep your eye on it. And if you have a dermatologist, they recommend visiting once per year to have different marks on the skin just checked and cataloged and watched every year to be sure that they're not changing in their appearance. If they do, that can signal danger. The good thing about skin cancers, though, is that if you avoid sun exposure, then that can help a lot in just prevention, because your skin does replace itself very, very quickly. It's called a highly labile tissue, which means it's constantly undergoing mitosis and constantly replacing itself. So if the irritant is removed, as we talked about in hyperplasia and even dysplasia, then the tissue can go back to normal. And because the skin has a high lability, then it is very good at that. But just as a note, as I said in class, when people have really low amounts of melanin, like me, for example, if you have very light hair and light eyes and light skin, and that person doesn't tan well, or they've had reactions to the sun and typically burn, their risk for melanoma is very high. So sun protection, sun exposure are all things that you should take into consideration. The rules of the mole are other things that dermatologists can help out with, but also just patient education. If somebody shows you something and says, does this look normal? If a mole, which is just a raised, overactivation of melanin, as long as it's symmetrical and there's nice even borders, there's a single color, and it's smaller than 1/4 of an inch, then it's probably fine. Again, you just watch it every year, ideally, and make sure it's not changing in appearance, especially in size. The things that make a mole or a lesion more dangerous, and you would want to take a biopsy of this if it's in a dermatologist's office. If it's asymmetrical, if the borders are uneven, if there's many colors, and if it's larger than 1/4 of an inch, those are all signs that that is an abnormal lesion and it should be biopsied and sent away for pathology. Just some little terms, you'll see the term mottled a lot, so that's referring to this mottling here, M-O-T-T-L-E, mottling. That's referring to that. I also want you to know and take into account that melanoma is a flat lesion. This is malignant melanoma, a very aggressive high-grade form, and in pure melanoma, you can see it from a mile away. I've told people at the pool that they should probably get something checked out because it's black. It is so dark as night black to purplish, and it's a flat lesion, and it can be removed and the surrounding area removed, and hopefully everything goes back to normal because of the lability of the skin. However, it does spread pretty aggressively, so it is recommended that patients keep an eye on anything changing on the body, anything larger than 1/4 of an inch, and anything with an abnormal appearance relative to our rules up here. Some common types of skin cancers, we've got basal cell carcinoma, so that's arising from the basal cell layer, which is underneath the epidermis. What you see is that this is a very slow growing tumor because the basal layer is down quite a ways underneath the epidermal cells. They do look pretty similar to just epidermal cells, but they have an abnormal color. You'll see that they look like raised red, almost like a mosquito bite at first or a pimple. And if people don't pay attention, they might think that they had a pimple and it's just not going away. So whenever there's a sore that doesn't heal or a lesion on the face that doesn't go away and it persists, it's recommended that that's checked out. This is different than squamous cell sarcomas because in squamous cells, remember, you'll see that they're infiltrating lesions because they grow downwards, whereas basal cells, they migrate upwards. So this is a raised lesion. And the other good thing about basal cell carcinoma is that it very rarely metastasizes. It's usually a local tumor that can cause some local destruction, which is what you see in this picture. There is a lot of luck with excision. So if this was removed with the undermost areas of the skin or layers of the skin removed along with it, there's pretty good prognosis there. Like all tumors, though, it can continue to grow. And why you see so much damage here, and do you see these little marks that looks like scabs? So that's not melanoma. The thing with tumors is, remember, they need a blood supply. And also we know that when we get to these uppermost layers of the epidermis, there's not a really great blood supply there. So tumors always, when they outgrow their blood supply, they'll necrose and then they'll ooze. So that's what you see here. We're seeing that this basal cell carcinoma has gotten so large that these areas have actually become ischemic and now they're necrotic tissue. So now this has become quite progressed, so we would call this local destruction. And even though it doesn't metastasize, it can cause quite a bit of local destruction, if not excised at a very early time when it's first seen. So really hammering in the point that anything that changes over time, or a sore or a pimple or anything that doesn't go away, that's something that should be checked out. We've already mentioned squamous cell carcinomas. Please remember that squamous cells are the outermost lining of things. They are very aggressive types of lesions, much more aggressive than basal cell. They can also metastasize, again, because squamous cells are on the top, which means their growth pattern is growing downwards, where they can infiltrate through the basal cell layer, the dermal layers, and go into the next tissue bed. If they're found early, if it's just a sore that doesn't heal, that can be excised with pretty good results. However, if it's not excised, it will continue to grow, causing local destruction and then possibly metastasizing. So here is a squamous cell carcinoma. This is the inside of the mouth. And you can probably guess, especially looking at the teeth of this patient, what caused this damage. This is something you will see with chewing tobacco, which isn't chewed if you're not familiar with it. It is in a pouch or a like fingerful of tobacco leaves that are put in between the teeth and the lip. We call this the buccal mucosa, so the innermost lining of the cheek. So it's held there for a few hours at a time. So we can see the local destruction to the teeth and the browning of the teeth, and this is the resulting squamous cell carcinoma. As I mentioned before, the white flaky part would be the first lesion. So if they went to the dentist and had their oral cancer screening and there was a white lesion there, that's something that can be watched. And if the patient reverses the behavior, then it has the likelihood to go away and not progress to a cancerous condition. This is a penetrating squamous cell carcinoma on the bottom of a foot. And for those of you who are wondering, how did this get so bad? You're going to see a lot of terrible pictures in this class. I apologize for that. But you can imagine that in a patient who has limited feeling in their feet, if they're not doing good foot health and foot check visits, then it could be possible that this would go unnoticed. And that wouldn't be abnormal if there were no feeling in the feet and the patient wasn't checking the bottom of their feet. So penetrating lesion, squamous cell carcinoma, outermost layer of epidermal surfaces. Okay, now we're in a really fun one. This is interesting. Teratoma. A teratoma is not just one germ cell layer. So it's not just cells from the mesoderm, ectoderm. It has more than one germ layer. So teratomas aren't malignant. They're not good, but they're not really malignant because they're encapsulated. So they can't move anywhere, but they're definitely not ideal. They arise from cells that can differentiate into many types of tissue, which means they're common in the reproductive tract because that's where stem cells are that might become various pieces of a human. When you look at ovarian cysts, most of them are filled with just serous fluid and some blood from ovulation, which means under a sonogram, the cyst can be viewed, but it would be black fluid on the sonogram that would be visible inside of it. If there was a sonogram performed and instead of seeing black fluid as you would expect in an ovarian cyst, if you saw white, that needs to be removed right away. That's a type of teratoma called a dermoid cyst. And imagine this, we have this cyst here of the ovary, and when it's dissected, you see hair in there. There is a tooth. There are pieces of a jawbone in here. So obviously this isn't just going to be resorbed and go away. It's going to need to be excised. So that's a really interesting finding. It's called a dermoid cyst. This is a very large, bulky teratoma of the female infant. And again, because it's reproductive tract related, these would be the areas that you would expect to find these. So inside of these would be multiple different types of cells. Very commonly, you'll see bones, hair, and other tissues like GI tissue can be present in there. And that's the pathologist's job. Isn't that fun? You get to cut them open and do a gross examination. All right, as I mentioned before, tumors do necrose. So here's another basal cell carcinoma that started to outgrow its blood supply and necrose and then ooze, and it will continually bleed. So it truly is a sore that doesn't heal. This is one of the findings that actually leads to the discovery of cancers in some cases, because if you see iron deficiency anemia in an adult, it typically means that they're losing blood. Adults aren't doing much growing, so they don't need to replace any iron because of a growth spurt. Instead, you associate that with bleeding. So one of the most common things that you'll see is GI bleeding causing iron deficiency anemia, and that's the first sign that there's a tumor in the colon. So even though this looks really terrible, it does have a good sign associated with it, meaning that it can be found, especially if it's in a place like the colon that's not being monitored for any kind of abnormal growth, unless that person is having regular colonoscopies. So the idea here is that whatever part of the tumor is the furthest from the blood supply relative to it will die. And that makes sense. You need blood to live. So the part that's most distal to the blood supply will necrose first. And that's going to be determined by where the tumor is. So for example, the way that tumors grow in the lungs means that the center of the tumor is furthest away from the blood supply. So that would be the site that's necrotic. On the epithelial surface, the most distal epithelial cells have the poorest blood supply. So this ulceration, it continually oozes, and sometimes ulcerated tumors can cause a severe hemorrhage, which means anytime blood is leaving the circulatory system, that's technically a hemorrhage. GI bleeding, very common, so that's a test that's done. It's called a fecal occult blood test. It doesn't have to be frank blood, meaning bright red blood. It can be blood that's not visible to the naked eye, and that's tested for during a fecal occult blood test. Okay, other things we need to go over for tumor types. There is a type of cancer that's very slow growing, still technically a carcinoma, but it's called carcinoma in place. In situ means in place. And what's different about these types of cancers is that they can't infiltrate the tissue next to them. They can stay there, they can keep getting bigger, but they can't go infiltrate the next layer. So taking a look at this picture, this is an intraepidermal atypical cancer, so a non-infiltrating squamous cell carcinoma, first under low power magnification, then high power. What you see pathologically is this nice border of abnormal cells. We can also see that it's made its way to surround a blood vessel or a lymphatic channel, but you see these fun little extensions? It grows in this rippled-like fashion. So here's our abnormal cells, but also I want you to notice that it can't go to the level above it. So it is similar to a benign growth in that it's encapsulated. So we have this fibrous tissue around it, and we have on both sides, so a little bit here and then here, and this is going to limit its ability to move. So you can see this in lots of places. This is very common when we think of cervical cancer. Most of those are non-infiltrating in situ carcinomas, meaning it can affect the epithelium of the cervix, but it's not going to go anywhere else. You can see this in the breast tissue, urinary tract, colon, and skin. And the good thing about in situ carcinoma is that they are slow growing. It's kind of like severe dysplasia, which you'll see on the next slide. So we have these epidermal ones here. This is a urethral meatus. So this individual luckily got his urethra checked, and that redness there, that's actually in situ carcinoma of the lumen of the penile tract. So this is just the animation from National Cancer Institute. Here's our normal cells. Here's hyperplasia or excessive growth, mild dysplasia. So those cells mostly look good. Some are starting to look bad. We have a little bit of abnormality with stratification here. But carcinoma in situ, there are pleomorphic cancerous cells, loss of stratification, but it stays in its tissue level. It won't go below the basal membrane, for example, if it started in one direction. And that's different than full-on invasive malignancies, which can invade. So carcinoma in situ is non-infiltrating. It stays in its tissue level. Okay, so before we finish this up, and then in the next lecture, we'll talk about the genetic contributions to cancer and then go on to treatments. Screening is something that can be done by blood tests, by x-rays, by lots of different ways that cost a lot of money. And the good thing about the skin is that it's readily available to the naked eye. So we don't have to do fancy things for for screening for skin cancers. You just have to look at it. These are all precancerous conditions, meaning if the patient suspends their irritating activity that's causing damage to these cells, then we generally, if it's on the epithelium, expect it to regress. If the individual continues to engage in that activity, then it will go on to become a more aggressive type of cancer. So these are all precancerous lesions that can be avoided from going further if found appropriately. And the first one is actinic keratoses. So this is a scaly type of lesion that you would expect to find in skin exposed or sun exposed areas of the skin. if we're just looking at this patient, so if they're not wearing a hat typically, if they're going outside most of the day, this is in a very high sun exposed area. And this flakiness, this is just a overproduction of keratin. So if you wanted, you could clear that out, or you could say, let's wear a hat, stay in the shade, and come back in 6 months and see how it's progressed. So actinic keratoses, small crusty patches that can progress into a more progressive cancer, but can be found earlier. A pre-melanoma lesion is called lentigno maligna. So that is a darkening of a portion of the skin, telling you that there's damaged melanocytes. And as we know, we've got these rules of the mole. If this is not a birthmark, this would have to be checked out. It's quite large. We see that there's uneven borders, and there's some mottling of color there. There's some multiple colors involved. This is a very high sun-exposed area. Your nose is out further from the rest of your face, meaning it's the first thing to come into contact with the sun. This is another thing that the patient can be asked to wear sunscreen to stay out of the sun and see you in 6 months, and let's see if this has regressed or progressed further. Finally, I've mentioned this before, this is leukoplakia, or white flakiness. This is typically inside the mouth, either on the mucous membranes, the tongue, the buccal mucosa, and it's seen as white flakiness. And it's very common to see this in patients who have long exposure to tobacco products. And when I say long exposure, so cigarettes, for example, they take a couple of minutes to smoke, whereas chewing tobacco is kept in the mouth for hours. Pipes and cigars are kept in the mouth for hours. So the longer the exposure, the higher the likelihood of having damage to those cells. Your tongue is the most quickly healing organ in the entire body. So if this patient stopped the behavior that instigated this, this would be expected to regress pretty quickly. So these are all precancerous conditions that you should be on the lookout for and also be familiar with. All right, so we've mentioned a variety of these things a couple of times. Tumors have mass. They have a fibrous scrotum, stroma, they have a vascular stroma, and they are hard. They push normal tissues out of the way and kill our healthy cells. So you get tissue destruction. If that healthy tissue is an organ, it compromises the organ by compressing it. Tumors also engage your immune system, so the body is engaging in fighting against these tumor or cancerous cells, which takes a lot of energy generally. Also, it takes advantage of a lot of the things that the marrow is doing generally. So you'll see repeated infections because of immune suppression. Anemia can either be because the tumor has started to necrose and is now bleeding, or it could be because there's a physical disruption of the blood flow, like you see in this top picture here. Or if it's in the marrow causing marrow disruptions, it could be due to a low amount of red blood cells. When there's direct invasion of a tumor into a tissue, it also hurts very badly for the patient. When there is a malignancy that's growing inside of anything that's encapsulated, so like testicular cancer, for example, that's in a non-flexible capsule. So as that starts to grow, that causes a lot of pain. If it's in the marrow and the marrow is growing, there's nowhere for that to go. So the pain in the bones will be quite pronounced. So there's pain involved, which with anemia and immunosuppression leads to a lot of lethargy, feeling tired, and feeling very unwell. Tumors also do really terrible things to your body. They don't just sit here like a non-active tissue. They secrete products. So for example, some lung tumors secrete insulin. So the sign in that patient would be that there's abnormalities to the level of glucose in their blood or dysregulation of what we call glycemia. In testicular cancer, you see the secretion of HCG, human chorionic growth hormone, which is what is tested for in a pregnancy test. So in a urine pregnancy test, it's looking for HCG. It's something that's released when an egg burrows into the uterus and starts to grow. So you would never expect to see that in a man, but with testicular cancer, you'll see that it can secrete that. So it does weird things. And whenever hormones are out of balance, you're going to have the entire system starting to go out of homeostasis. This is a very late stage cachexia patient, and cachexia refers to a wasting disease. And the reason you see cachexia in cancer is because tumors, they rely on glucose for an energy source in the same way our cells and our body does. We love glucose, our body runs on it, our brain runs on it. Tumors, they physically shuttle in glucose to them. They have glucose receptors that they express so that they can have the energy that they need to keep dividing and growing and proliferating. One interesting pharmacology fact is vitamin C is co-transported into cells along with glucose. So if you ingest a lot of vitamin C, the body will make more glucose receptors to traffic it into cells. What that means for cancer patients, vitamin C is actually contraindicated with them because the more vitamin C you have, the more glucose is going to be made available for the tumor. So it actually promotes tumor growth. So that's something that we don't even think about as a drug, it's just vitamin C, but it is contraindicated with tumors. So just keep that in mind. Know that they run on glucose. And when they run out of glucose from the diet, they will take it from the muscle, from the fat, all the places that we store glucose, which does lead to wasting diseases along the way. So know that as these tumors are growing, not only should we know the basics of them, but we should also know the way that they run and the damage that they do to the body by taking advantage of all of the things readily available for normal tissue healing, for normal tissue growth, and also for normal bodily activities and function. All right, next lecture will be on screening and treatments, and I will see you with that shortly.